Hi, everyone. I am thrilled to have Dr. Stephanie Blank with us today. Dr. Blank will talk about ovarian cancer treatment updates. And the description is coming off of the SGO annual meeting on women's cancer. Dr. Blank will share exciting advances in the management of ovarian cancer. This will be a big picture perspective of the progress that has been made in the field. Dr. Stephanie Blank is the director of GYN oncology for the Mount Sinai Health System and a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the Icahn School of Medicine at Mount Sinai. She's also the director of Women's Cancer Program at the Blavatnik Family Chelsea Medical Center at Mount Sinai and the director of oncology programs at the Blavatnik Family Women's Health Research Institute. Dr. Blank specializes in treating patients with gynecologic cancers, including ovarian, fallopian tube, primary peritoneal, uterine, and cervical cancers, and in caring for women at increased risk of cancer. Thank you all for joining us today. As Dr. Blank mentioned, if you do have a question, you can write them right in the chat and we'll get to them throughout it or at the end. Dr. Blank, thank you so very much, and the floor is yours.
You see my slides?
I don't see them. Also, if you could, everyone mute yourselves except for Dr. Blank, that would be fantastic. I don't see them.
I messed up.
Oh, sure. Got them.
Now?
Yes.
Okay. Phew. I will mess up, I'm sure, once or twice during this talk. So thank you, Jillian, so much for inviting me to speak here. I love to speak to this group. You are such a smart and engaged group. I always learn something from speaking to you. And then I always want to look it up and come back and tell you the answer. So anyway, we'll go on. I also never time my talks in advance. So if I go over, I apologize. I do have some, it's not personal funding, but the institution gets some funding. I don't have any personal disclosures. So this to me, this is just a picture to me of hope. And I think, you know, I go into speaking about ovarian cancer with a lot of hope and optimism. And if you know me, you know I feel that way. And I hope that comes across as we go through this talk. So hate to start with a graph, but I have to, so because this is like data. I'm very driven by data. So this graph is, you know, the light green is the rate of new cases of ovarian cancer in our country over time from 92 to 2019, and we always lag in our counting. And the dark green is the rate of deaths over time from ovarian cancer. And the important thing to note here is that both are dropping. There are fewer people that are being diagnosed with ovarian cancer, and there are fewer people dying from ovarian cancer. These are both dropping at rates of about 3% per year, which is fantastic. The amount by which they're dropping is increasing as well. Now, why are fewer people being diagnosed? The main reasons are birth control pills and people finding out about their increased genetic risk and removing tubes and ovaries preventatively. The reason that people are living longer is because we're finding more ways to treat recurrent disease. So these are definitely promising findings. Is we've really learned a lot over time. You know, we can answer questions about ovarian cancer that we never could before. And I'm going to address a lot of these, but not at all in this order. So I should have really rearranged the slide. So first of all, let's start with what. So in 2016, the National Academy of Medicine convened a panel of experts and looked at the biggest opportunities that we should study in ovarian cancer. And they really looked at these 5 things. They wanted to look at the specific disease subtypes. They wanted to increasingly focus on precision medicine. They wanted to improve understanding of genetic and non-genetic risk factors, screening and early detection. They wanted to think about consistency in the delivery of the standard of care, as well as increased attention to survivorship issues, including supportive care with long-term management of active disease. Thankfully, people are living a lot longer. So now we also have to, you know, figure out how to help people live better. before I go on, I just always make this point that we're actually, when we're talking about, most of the time when we're talking about ovarian cancer, we're talking about tubal cancer. And this graphic basically shows how that happens. They're basically the cells start in the tube and basically sprinkle themselves onto the ovary. And we used to not necessarily know this because the way the pathologists would process the sample, they wouldn't pick this up. But in the early 2000s, the way the pathologists looked at the samples when they got them in the lab, they started finding these precursor lesions. And that's how we know actually a lot of people that always thought they had ovarian cancer actually have tubal cancer. That's more like just a word thing, if you will, because we do treat them the same, but just interesting to know. It's going to be of a little bit of interest when I speak a little bit later on about a trial that we have. So the first thing that was in that report is that ovarian cancer is a spectrum of conditions. So some of the ovarian cancer look like tubal disease. Some of them look like the lining of the uterus. Some of them look even like the kidney. Some of them even look like the cervix. So ovarian cancer looks like a lot of different types of tissue. And if it looks different, oftentimes it behaves different. And this is basically a breakdown of all the different kinds of ovarian cancer. When I talk about it today, most of the time I'm talking about the serous, high-grade serous, the one that I showed you initially. When we look at the mutations, sort of the changes in a cell that actually probably drive those cells to become cancer, there are a lot of different drivers of these changes. And it's not just like there's one driver with ovarian cancer. There are a whole bunch of them. They're all on this side of this graph that are associated with a process called homologous recombination deficiency. And I'll speak about that in a little bit. But there are also some that are not associated with that. And we're still learning a lot more. Basically, the take-home message here is that one size does not fit all. We have to find the right patient, the right drug at the right time, and it's not the same for everyone by any means. So this is a little graphic of FDA approvals in ovarian cancer over time. So anytime there's a new drug, it goes through a lot of clinical trials. It has to be, found to be safe, then it has to be found to be effective, then it has to be presented to the FDA. It takes a lot of work. Companies have to invest in this. These are all of the drugs that have been approved in ovarian cancer over time. And what you can see is that this is really weighted towards the now. And there have been more approvals since 2014 than there had been in the prior 60 years combined. So there's been a lot going on of late. If I were giving this talk 20 years ago, it would be much shorter. You might be happy about that, but there's really been a lot going on. And the most recent approval is a drug called mirvetuximab, and I'll speak about that towards the end of this talk, which works in a totally different mechanism. Interestingly, the last time a chemo was approved was in 2006. Everything that's been approved since 2006 is a drug that works differently than chemotherapy, although chemotherapy plus bevacizumab was approved here in 2016, but there's a different drug there as well. So, one might say that we're sort of in like the golden era, the Renaissance in the care of people with ovarian cancer. And so much is happening. There's a lot of progress and advancement. And this isn't to say that we're, going to go downhill from there. But really, how did this happen? And it's really by people working together. And the key to that is research funding, clinical trials, and education. So this is a basic treatment paradigm for ovarian cancer. And there have been big paradigm shifts over time. So things that are different. Back in the day, nobody would give chemotherapy before surgery. Now that's done quite often, and it's standard of care in some situations. We sometimes give drug along with chemotherapy at the beginning of treatment. They used to do surgery at the end of frontline chemotherapy to see how people responded. That's no longer done. This is a big change. Maintenance after frontline treatment. And the other thing that's very interesting is that we now have these, people are getting more and more and more lines of chemotherapy because they're living longer, as I mentioned. Now, what's exciting about all this is all of the places we can and can continue to make progress. So here we can prevent, we can identify people and increase genetic risk for ovarian cancer and prevent cancer. We can educate people about the symptoms of ovarian cancer, and we can diagnose it sooner. I'm not going to talk actually a lot about that. We can make sure that once somebody has ovarian cancer, they get to the right doctor and they get the right treatment. And they get the right decision about upfront treatment versus not. They get the right surgery. By using the right drugs upfront, we can cure more patients. That used to not be something we really spoke about. Using drugs for later is really using traction. That used to be something, let's not use that drug now. We're going to wait and use it later. That's not something we generally do anymore. And all along the treatment journey, we can select the right drug for the right patient at the right time. This is what SELECT is. And we can also improve the lives of people living with cancer. So we think about it now more as a chronic condition, and we focus on quality of life. So I'm going to start here with prevention. And so when I start with prevention, I always start with genetics. And why is that important? By using genetics, you can find people at increased genetic risk for ovarian cancer. And if you find people before they have ovarian cancer, you can prevent it. So that oftentimes ovarian cancer is one of the cancers, it's actually the cancer that has the highest proportion of people with genetic risk. So we used to think that about 10% of people with ovarian cancer had a genetic risk, and that most of those were BRCA1 and 2. But now we know, and this was done by looking at the DNA of almost 1,500 women with ovarian cancer, we now know that I'm going to add these up in my head. Almost 30%, is 29% of people with ovarian cancer do have some sort of mutation that's predisposing them to cancer. And it's not all BRCA1 and 2. So 29% of these, I'm sorry, that number back was 20%, not 29%. This is the 29%. I apologize for that. So 29% of the mutations that people have that are predisposing them to cancer are in non-BRCA genes. So we're learning a lot more. So why is this important? If you have ovarian cancer, and you probably all know this already, but I'm just saying it anyway, it's very important that you get genetically tested. And it's important because it is important for prognosis, it's important for determining your treatment. But it's also important for you to share that information with your family, because if family members get tested, then they can take preventative strategies, and that's how you can prevent cancer. When you do this, it's called cascade testing, hence this picture. You can also prevent cancer because if you have a gene that predisposes you to cancer, you might be prone to other cancers. You can take measures to prevent those cancers. So if you have somebody that has a genetic predisposition to cancer, how do you prevent it? Well, if you have somebody with a BRCA1 or 2 mutation, there's 2 ways to prevent cancer. One is birth control pills, and the other way is to remove the tubes and ovaries preventatively. And in people with BRCA1 mutation, the recommendation is age 35 to 40. And in people with BRCA2 mutations, the recommendation is age 40 to 45 years. Now, just think about that. Does someone who's 35 really want to go into menopause electively? It's sort of a very big decision, and there's major impact on quality of life. So even though this is recommended and people want to do this, people generally do listen and do this. There's certainly, some thought that's being going into, seeing if there's a better or another way. So the other way that we're working on is something called risk-reducing salpingectomy, removing the tube first and removing the ovary at a later time. So making it into a 2-step process. Not that 2 steps is better than 1, but you can remove the tube when you're 35, not go into menopause, remove the ovary when you're 45. So you're not having that many more extra years of menopause. And this is something that, removing the tubes and ovaries at these early years has been shown to make people live longer. It actually saves lives. I know that sounds like overly dramatic, but it really is the truth. We don't know yet if removing the tubes does that. And why does removing the tubes work? Remember that very first slide I showed you where I was explaining that a lot of tubal cancer, and especially the ones that happen in people with mutations, start in the tubes. Well, we think if you remove the tubes, you might be able to prevent cancer. So this is a more theoretical than anything else. It's actually considered to be experimental. So we have this trial going on here. It's called the SORAC trial, and somehow you get SORAC out of this this phrase. But basically, we look at people with BRCA mutations between the ages of 35 and 50, and they can choose whether they want to have their ovaries and tubes out versus their tubes first, ovaries later, and we follow them over time. We're going to need to follow them for 20 years or more to answer this question, and we're going to need over 2,000 people. This is not happening just here. This is happening all across the country, but this is really important research and will have potential to impact the lives of future generations. So this is the type of thing that I think can really be, well, it's very important. So the other thing that is important about removing tubes is this concept of opportunistic self-injectomy. And this got a lot of traction recently at the beginning of February in the news because there was a statement that came out basically saying that from the Ovarian Cancer Research Association recommending that women consider removing their tubes when they're having other surgery. So this is basically if you're having a hysterectomy or if you're having, fibroid removal, remove the tubes as well if you're not trying to use them to get pregnant, and that may diminish your risk of cancer. So we don't know that that does anything right now. That has been followed up in a province in Canada, and it does look like it is doing something, but that's sort of another thing that on a large public health scale may be working to diminish ovarian cancer. So in 2013, another New York Times reporter, Denise Grady, looked at a study that was done specifically at the SGO, and they basically looked at these are NCCN guidelines. These are basically, it's almost like these are standard care, and it's been found that if you follow these guidelines in your care, your patients are going to do better. But they looked at a whole bunch of places, and they found that there were widespread persistent flaws in the care of, this is terrible, of women with ovarian cancer. And basically they found that only 1/3 of patients were receiving the best possible care. And you needed to go to places where you had surgeons that were doing 10 or more ovarian cancer surgeries per year and hospitals that were seeing more than 20 patients per year to do better. So this was a little bit more controllable than some other things, than biology or things like that. So it is something that just basically getting your care in the right place can have a major impact. We do know that getting cared for by a gynecologic oncologist makes people live longer, so that's part of it, and that seems like it would be pretty straightforward. But there aren't gynecologic oncologists everywhere. There's a pipeline problem. There are actually 28 counties in the country where there are no gynecologic oncologists. So it's really an access issue, and with a lot of governmental blah blah blah, we're not going to talk about politics, but a lot of things going on, it's getting harder to get people into rural areas. So that is a big issue in healthcare in general. It's not an issue to see a GYN oncologist in New York. You can find one on every corner, but if you're living in rural America, it's a little bit different. So let's just go back to bread and butter treatment of ovarian cancer. So frontline treatment, Taxol, paclitaxel is Taxol, and carboplatin remains the chemotherapy of choice. And the vast majority of patients are going to have a complete response to this. So the frontline treatment is the same standard. What is new? We have better supportive care. It's really much less common that people are experiencing nausea or a lot of the other side effects here. We have better medications for that. We have cold capping, which can help, people lose less hair. It doesn't always work. We also have wonderful supportive programs such as Woman to Woman. So there are very, really some things that make this process a lot different. Last year in 2022, I made this slide. I talked about the frontline treatment for ovarian cancer in general. So I made a new one for 2023. You're like, what is different? I'll go through it. So there's three little different things this year from last year. So I'm just going to talk you through this. I don't know if this is of interest because most of the time people on here have already gone through the front line. So I'm going to do it a little quickly, but if you would like me to review it, you can put it in the chat. I actually, Jillian, can't see the chat. So if there is something, do let me know. Okay.
Sure. There was a question. Was a question, but it could wait. It's not. It's fine.
So basically, when somebody gets diagnosed, there's the first decision is whether you're going to have surgery first or you're going to have chemo first. And then the decision with your treatment is whether you're going to have chemo alone or if you're going to have chemo plus Avastin, which is bevacizumab. When you're diagnosed, it's also very important that you get germline testing. That's testing if you inherited a mutation in your blood for everyone with ovarian cancer. And then it's important that you get your tumor testing, and that's called HRD testing. And I'll speak about that in a moment. So sometimes that's sequencing the tumor, or sometimes that's getting something called an HRD test. So either once you're getting your treatment, you're either getting chemo with or without Avastin. When you're done with your 6 cycles, the next question is, are you going to add a PARP inhibitor to maintenance? Are you going to have maintenance, and are you going to add a PARP inhibitor to that maintenance? There are some maintenance strategies that include Avastin. I always say bevacizumab, but it scares people sometimes. So I'm going to say Avastin, but I don't like using brand names, so I apologize for that. Anyway, so if you're not using Avastin, then your maintenance will not use Avastin. If you are using Avastin, your maintenance will use Avastin. And to rewind for a second, because I don't know how many of you have heard a million of these talks and how many have not, what maintenance is when you're finished with your treatment, your actual treatment of your cancer, you stop, and then you go on something that's going to kind of keep the cancer at bay, that you might be on for a long time, but you need to be able to live your normal life while on it. So it's a little bit different than treatment. And so you basically have to think about quality of life a bit more. It has to be more tolerable, and so it's a different decision. But maintenance is a big change in ovarian cancer over the past 5 years, and it's pretty much always a discussion with patients, at least with more advanced disease after they finish their frontline chemotherapy. So when you chemotherapy, if you were not on Avastin, you have a choice of going on a PARP inhibitor if you had a BRCA mutation or your tumor was homologous recombination deficient. And what I have over here is maybe not so interesting, but these are the trials that support that decision. And if you do not have a tumor that is homologous recombination deficient, this is a decision you would make with your doctor about whether or not you're going to go on a PARP inhibitor. So if you think about things that make sense, so a biomarker is basically a test that you will do on your tumor, and if you have a target there, you would use a type of medicine that will target that target. So that it basically is trying to see if the medicine is going to work. It's trying to predict. And we have that for a lot of different medicines. In PARP inhibitors, seeing if you have homologous recombination is sort of like a key if a PARP inhibitor is going to work. However, in some PARP inhibitors, one called niraparib, for example, 10% of the time, somebody who does not have the HRD will respond to the PARP inhibitor. So it becomes a little bit tricky in knowing if you should sort of not take this treatment because you have you do not have that biomarker. So I hope I'm not confusing. I'm sure I am, but I'm going to keep going for now, and you can certainly ask questions. And then, so if you are on bevacizumab, you again make the decision if you're going to add the PARP inhibitor or not. And again, those are basically all of the discussions there. So these curves are basically the 4 studies all looking at PARP inhibitors in the front line for maintenance, all of which show that people do better. They have a longer time without anything coming back when they're on a PARP inhibitor. And this is different depending on, I'm sorry, you don't have to read this. This is just sort of like to demonstrate a point, but all of these PARP inhibitors are different, have different results depending on whether you have a BRCA mutation, have homologous recombination deficient tumor, or do not. And if you want to think about it, in general with the PARP inhibitors, people that have BRCA mutations will do best. Those that have homologous recombination deficient tumors will do second best. And those that have homologous recombination proficient tumors, or those are the ones that do not have homologous recombination deficiency, still may do fine, but they will not do as well as the others. So I'm going to take a sip of water for 1 second. Well, I find it, sometimes people are throwing this word around, HRD. That's what we're testing for. I thought I would try to explain homologous recombination very quickly in a very simple way. So you know what it means when it's thrown around. If you're watching this, you probably watch these kinds of things and you've probably heard of HRD before. So homologous recombination repair is one of the body's ways of basically spell checking DNA. When DNA is making more of itself, when it's copying, it always makes mistakes, but it has different ways that it corrects mistakes. And this is one way. This is a way that uses some proteins such as BRCA and other homologous recombination associated proteins to fix it. So using these proteins, you have this break, these proteins come in and they fix it, and you have a perfect repair. Now, if you have a homologous recombination, if you have somebody who is homologous recombination proficient, you see what we just looked at, okay? So it works. If you have somebody who is homologous recombination deficient, or HRD, this does not work. And I'm going to show you here. And the reason why it's important is because when you bring a PARP inhibitor in, that kind of gives you a situation called synthetic lethality if you have homologous recombination deficiency. So the green here are homologous recombination proficient, and this is homologous recombination deficient. So this is a normal cell. Oops, we have a single strand break here. So let's first start with somebody not on a PARP inhibitor. Somebody not on a PARP inhibitor, their PARP will fix some of their DNA, and their homologous recombination will fix some of their DNA, and their DNA is all going to be fixed via PARP and via homologous recombination. The same person who with homologous recombination that is proficient, they have the break again, but they are on a PARP inhibitor. They have the break. BRCA comes in and fix it. PARP can't fix it because they're on a PARP inhibitor, but they can rely on that other repair pathway, that BRCA pathway, to fix their DNA. But if you have somebody who has a BRCA mutated cell that is homologous recombination deficient, they get the single strand break. The PARP mechanism doesn't work because you're on a PARP inhibitor, and the homologous recombination mechanism doesn't work, so the DNA is not repaired. That's basically how that works and why those medications work better. It's kind of simplistic, but it makes sense to me anyway, so hopefully that's helpful. So when you look at
Dr. Blank, there were 2 questions about PARPs in the chat. Do you want to address those now? I could read them to you.
Okay, yes.
So the first was, how long do PARP inhibitors keep cancer at bay in general?
Great. So in general, it really varies depending on your biomarker. So in some of I'll show you momentarily with the BRCA and the solo one data, the progression-free survival, for example, has not even been met yet. So we don't even have a median progression-free survival at that point. When we have that answer for sort of the people that have HRD but not BRCA mutation carriers, it's on the realm of 2 to 3 years. And when you have wild type, it's more like a year and a half or so. But that's significantly better than it is without those medications. I actually see the chat now.
Okay.
Hasn't the FDA removed approval of niraparib for BRCA negative patients based on last clinical trial? This is a great question. At this point in time, the changing of indications for PARP inhibitors is not for the front line, it's for the recurrent setting. So before we used PARP at the very beginning, we used to use them when somebody's disease came back. When they were done with their treatment, they would go on PARP maintenance. But you are correct in that the FDA has removed the indication for people without BRCA mutations in that setting, but not yet in the front line. They've also removed the indication for PARP inhibitors simply for treatment of people with BRCA mutation. They used to be used for treatment alone, and that's no longer the case. I am looking at some of these other questions. I'm going to answer them now just because. There been any new findings on results of 6 cycles of chemotherapy for stage 1 versus 3 cycles? That's a great question. The one study that looked at that really showed that they were pretty equivalent, 3 versus 6. And it was a very difficult study for the people that did that study to do, because it was hard to get enough patients to do that study. So I don't know that it will be repeated. So I think at this point in time, we are going to have to live with those data. There's nothing new with that. There was another question. If you're doing well on a PARP medication, can you stay on past the protocol? Great question. I think, in the front line, olaparib is for 2 years, niraparib is for 3 years. I generally do not recommend people stay on longer. I think we're still learning about the long-term effects of PARP inhibitors, hence some of these removal of the indications. In the second line, when you have people on, those indications were forever, but a lot of us are taking people off at 2 years for the same reasons that I'm saying. That being said, I have some patients that have been on for years and years and years. There are certainly risks, but is not necessarily better. I know it's a little scary to go off a medication that has done so for you, but there certainly are risks. Doctors still recommend a chemotherapy maintenance plan of chemo so I believe this says, do doctors still recommend a chemo maintenance plan of once a month for a year? I believe that's talking about chemotherapy. Once you finish your frontline therapy, having chemo once a month for a year afterwards. I don't think that is really done anymore right now, because we have either bevacizumab or PARP inhibitors. The study that looked at that didn't lead to a great acceptance of that as a maintenance strategy, because there are a lot of side effects to chemotherapy. So when you're looking at maintenance there, weighing the risks and benefits of getting all that chemo and its impact on quality of life, that really never really picked up to that degree.
I think those are all the questions so far in the chat.
Okay, this is more about the homologous recombination genes. We sort of talked about this a little bit ago. So I just wanted to now talk with you for a minute about what HRD is. So in a newly diagnosed person, your tumor can be sent for HRD testing. And there are two ways to be HRD. If you have a BRCA1 or 2 mutation or any other mutation of a drug that's involved in homologous recombination, then you might be HRD. In your tissue, if you have a mutation that's called a somatic mutation in one of those, you may be HRD, or there is an HRD score. So I'll talk about that for a little bit. So the score doesn't only look at mutations, it also looks at some other findings, and it is more likely to find ways for you to be homologous recombination deficient. So there are several companies, and I'm not partial to any one company, that do this type of testing. And what they end up giving you is a number, and there's a cutoff for the number, and you either learn that you're homologous recombination positive or negative. And this has meaning in the frontline setting because that determines, a lot of times it helps inform your decision about PARP inhibitor versus not. But HRD doesn't have as much meaning in the recurrent setting, which is somewhat interesting. In the recurrent setting, when we were using PARPs, it didn't have meaning that it wasn't a biomarker that predicted response. Really, BRCA status did, but this did not. Well, I just went through this. I think I had some kind of closing thing I was going to say about that, but I don't remember what it was. So we've talked about frontline. That's what I was going to say. Oh, so I wanted to speak for a second about, so some of the newer things that have come out is the longer term follow-up of some of these early PARP inhibitor trials. So SOLA-1 is the one that looked at specifically at people with BRCA1 and 2 mutations, either in their blood or their tissue, and they were randomized to get either PARP or not PARP after finishing their frontline treatment. And that was even if they didn't respond all the way to their frontline treatment. And the main thing that they were looking at the end of that is progression-free survival. That means the time from when you're first diagnosed to anything coming back. And initially, when things were presented, it was much earlier. As I mentioned before, this treatment went on for 2 years and then it stopped. So one important thing to note here is that lots of times when we've had these treatments that we've done in maintenance, once we stop the treatments, these two lines come together. We call that the banana sign, but that doesn't happen here. So these stay apart. So what we know from that is that the effects of PARP continue going on. So that's a very good thing here. The other thing that I will say is that at this point with the progression-free survival, we have a median PFS. And what that means is that half the people have more than that and half the people have less than that, of 56 months. And that is a very long time, 5 years, versus placebo, which is a little more than 1 year. And so that's a difference of 42 months. That's 3.5 years difference. I think everyone would argue that that is clinically significant. And now in the 7-year follow-up of SOLA-1, looking at overall survival. So overall survival is when you're, this is from when they're done with their chemotherapy till, I'm sorry to say, when they pass. And if you look at this, talk about median, that's when half of the people have passed and half are still living. That hasn't been reached yet at 84 months. And so they're still, this is really pretty dramatic. At this point in time, it's still a very dramatic thing. Now, and the other thing that's very interesting here is that the placebo group, 40% of the people in the placebo group actually went on to get PARP inhibitors later. So it certainly speaks to the fact that there's something special about getting these drugs up front. I was going to mention this trial. This was something that was presented at SGO. I found it a little bit interesting because it was a trial of BRCA, and I'm not only going to speak about BRCA1 and 2. This is the last thing about BRCA1 and 2. Okay, I promise for the people that didn't only want BRCA1 and 2. This is a trial that used a PARP inhibitor, olaparib, at right when somebody was diagnosed with ovarian cancer, they gave them 2 months of olaparib and then took them to surgery and then gave them chemotherapy. And this is kind of a new approach to treatment. That now is the acronym for whatever the trial was called. It was called neoadjuvant olaparib something or other. So again, they got 2 months of olaparib. If they progressed or they didn't want surgery, they went straight to chemo. If they had any kind of response, they went to surgery, and then they went to chemotherapy, and then they went to maintenance. And this was really, they didn't do a ton of patients on this. This was really to see if it was feasible. And basically, they did find that in general, it was feasible. One patient didn't ever get any chemo at all. She just stayed on a PARP inhibitor, which is interesting. And overall, almost everybody had some sort of response to treatment, the PARP alone. So that's just an interesting little thought for you. Just talk about the longer term treatment paradigm. So we've gone through the first half of it here. So you're finishing your maintenance. Okay, so it's either 2 or 3 years. So some patients are going to go on and be cured. Somewhere there, I saw something that said that's going to be 17% of people. This may be higher. We don't know right now. We're still learning about that. Ultimately, the majority of people, I'm sorry to say, will progress, will get additional treatment. Chemo, it may be chemo, it may be a non-chemo treatment, and that will go on for some time. So basically, when we talk about recurrences, we tend to talk about them traditionally in terms of platinum sensitive and platinum resistant recurrences. That's basically how in general we think about them, or we thought about them, because this is changing. So platinum sensitivity is defined as the time from which you last had platinum, and if you recur, if your disease comes back less than 6 months from last time you had platinum, it's platinum resistant, and it's more platinum sensitive. And that basically, if you have platinum sensitive disease, your next treatment generally includes platinum, and if it doesn't, it generally doesn't, although that's changing as well. So how do you make a decision? General, when you're treating somebody for cancer that's come back, there's no single best treatment option for people with recurrent ovarian cancer. There's absolutely no one treatment. And so every time you're looking at treatment, it really should be determined via shared decision-making. So it's about the side effects, it's about the schedule, it's about what's important to you. There's never been, actually there's one time where things were done head to head, but we don't know that that's the very best. So that's just better than one. So I think that's a really important point. We did some work here looking at what's important to patients, and we really found that goals and priorities change over time. And I don't think you really need to just say, okay, I'll take whatever you're the doctor, tell me. You should think about what you want and what's important to you. So I put this in because this was an interesting study that was presented at SGO. This is out of the Cleveland Clinic, and they basically looked at their patients that were on clinical trial. They looked at all of their patients with platinum resistant ovarian cancer. Remember, those are the patients whose ovarian cancer came back less than 6 months from the last time that they had platinum. And they looked at about 300 patients, something like that. And I think 40 something or 50 had been on trial. And what they found is that those that had been on clinical trials lived about 3.5 months longer than those that had not. I just found that interesting. There's a lot of problems with that study. Okay, there's a lot of problems with that study, but I'm a huge proponent of clinical trials. And I think that you can say they're being watched closer, they're healthier. There's a lot of things that you can say with that, but I think there's sort of among a lot of people, there's a thought that clinical trials are like the last thing you do, at the end, but it's not true. It really offers you an opportunity for some good treatments. And clearly there can be some benefits there. So I mentioned just a moment ago about thinking about moving beyond categorizing ovarian cancer recurrent as platinum sensitive or recurrent or resistant, sorry. So one thing that's important is it's so arbitrary when you say somebody has recurred. So if you check somebody's CA-125 every month, you're going to find a recurrence sooner than if you check it every 3 months. And there's not necessarily a reason to go about doing that. I do not recommend checking a CA-125 every month, every week, or anything like that. It's very, very arbitrary. So there are a lot of different thoughts going on right now about deciding how to categorize things. So now I wanted to talk for a little bit about, I'm really going over, about a couple of newer treatments for ovarian cancer, and I'll just do this pretty briefly. So one class of drugs that has that is really, I think, gaining a lot of attention and you will be hearing more about are antibody drug conjugates. And I have the next slide, I show it a little bit better, but these basically target specific proteins on the cells, and they get enveloped inside, and then they spit out this toxin that is really would be too toxic for you to have in your bloodstream, but it's not too toxic for the tumor. And basically, the thought is maybe these would replace chemo because, for example, mirvetuximab, which I'll show you in a moment, what it is delivering is like a really supercharged form of Taxol, sort of much stronger than what any human being could take, but it's delivering it straight to the cells. So this is what the antibody drug conjugate components are. So this part is the antibody, and it's very, very selective. Part is the payload. This is really toxic stuff that you have to you can't release it until you want to. And then this linker is really important because it has to be stable in circulation, but then it releases drug when it needs to. So mirvetuximab, and I can't tell you what the brand name is. This was approved, FDA approved in last fall. I think it was in October. And this is a antibody drug conjugate against folate receptor alpha. And this is indicated for people with platinum resistant recurrent ovarian cancer. And to learn if you are a candidate for this, your tissue needs to be tested for folate receptor alpha. So that's something worth asking for, even if you're not getting treatment right now, because it takes a little bit of time to get that treatment. I'm happy to give you more information about that if you want. And again, I have no industry anything. And my next slide, I show you a little bit of the data on that. Interestingly, when they developed this drug, they were giving it to everybody that in their study that expressed this receptor. But what they found is that only people that expressed it highly had enough benefit from it. So that's an interesting one, and an important one. I think we're going to be hearing more about it. Another important one of these agents is it's called UpRi, and the reason for that is because it's really a long name. And this is has an antibody against what's called anti-NaP2b, and we have a study looking at this in a maintenance setting. So the thing about these types of treatments is that they really don't have that many traditional chemotype side effects, but they do have a weird side effect, which can be a lot of dry eye. So people you need to go to the ophthalmologist quite a bit when you're on these agents. That's a factoid. I don't want you to worry about that, but it's just, when we get into these new classes of drugs, we're dealing with new classes of side effects, as you know. So this is the data that got mirvetuximab approved And basically, when they looked at people, and these people all had had a lot of prior treatments, up to 3 prior lines, 71% had their tumor shrink. And that's really pretty good. So that led to an accelerated approval through the FDA. This is from SGO, and I found this to be kind of interesting. So in general, immunotherapy has not been hugely successful in ovarian cancer. And what this study did is it took a type of drug called a tyrosine kinase inhibitor, which is a pill, and they used it with immunotherapy in patients with ovarian cancer. And the one reason why this is interesting is because this approach has worked very well in endometrial cancer for patients that didn't respond to immunotherapy by itself, did respond to it when given with this type of drug. And this is just very preliminary, but you can certainly see that there's a big difference. These people only had immunotherapy. These people had both, and this is a 6-month difference. So this is very preliminary, but I'm supposed to give you exciting news. So this is exciting news. The other thing that's exciting here is that they could check for a marker, which is called ARID1A, which is a protein that's on ovarian cancers, a different type of ovarian cancers than the PARP. So this is going to be a whole other subgroup of ovarian cancers that we're going to find something for. So I found this to be very interesting, and I was happy with that. This is just, I don't know why I put this in. This just shows that it was eliciting an immune response. So basically what that extra pill does is it makes the tumor hotter so that the immunotherapy can find it better. These are just some other ways that you can make immunotherapy potentially work better in ovarian cancer. In this study, they used PARP inhibitor with the immunotherapy, and it worked better than traditionally immunotherapy would. Here, it was used with Avastin and an oral chemotherapy, also doing very well. I found to be interesting because this drug, they used a drug that's actually used for neurofibromatosis, and they combined it. They used it for patients that had already been on PARPs, but they progressed. And they combined the two drugs, and they basically found they were doing a lot of it in test tubes, and they found that they were working well together. I'm sorry, and then in animals, they were working really well. And then they basically found that it was working decently well in patients as well. And so once patients develop mutations that make them not respond to PARP inhibitors, we may be figuring out ways to get them back and get them responding to things. So this was an exciting study. I'm not doing it justice. I apologize for that. I think this is the end. This is the end for me. I think there are a lot of questions. I thank you for your interest.
Thank you so very much for so much information in a very short amount of time.